Tuning in glamorously from Lisbon today, Dr. Sabiha Gati is a consultant cardiologist specialising in inherited cardiac conditions at the Royal Brompton Hospital, and she is the lead for the sports cardiology service. So today, Dr. Gati will speak of exercising safely with Marfan syndrome as we all digest our lunch. Welcome, Dr. Gati.
Thanks, Victoria. I'm just going to share my slides with you. So hello, everyone. My name is Sabiha Gati, and it's a pleasure to be here to give this talk. I am going to talk about the exercise recommendations in individuals with an aortopathy, which also includes patients with Marfan syndromes. I have no disclosures. So the exercise recommendations in athletes have been available for the past 2 decades, but these have been confined to individuals who are young and competitive and participating in the highest echelons of sport. In contrast, the general population also engages in recreational or solo exercise, and these individuals generally have a high prevalence of risk factors for atherosclerosis or other cardiovascular abnormalities. Now, it's well known that exercise curbs many of these risk factors for atherosclerosis. It reduces inflammation, it modulates autonomic tone, it improves tissue perfusion, and by doing so, it's associated with a reduced cardiovascular morbidity and all-cause mortality. Now, with an increasing prevalence of a sedentary lifestyle and increasing trends towards hypertension, obesity, and diabetes, clinicians are now being encouraged to promote exercise in all individuals, including those with cardiovascular abnormalities. There is an exercise paradox in that exercise may be associated with an increased risk of an arrhythmic sudden cardiac arrest or a sudden cardiac death in a small proportion of individuals with cardiovascular abnormalities. But equally, we've got to remember that exercise brings us many benefits. And so as we try to promote exercise in all individuals, there will be questions and concerns from both patients and clinicians as to what is regarded as the safe and correct level of exercise that one can do. So the 2020 ESC guidelines in sports cardiology were the first to address exercise in all individuals. This document covers how to assess the disease process, risk stratify, assess the current level of exercise, and then to prescribe exercise as well. And there's also a big focus on shared decision-making between the clinician and the patient who wants to exercise. So let's go through the exercise guidelines in individuals with an aortopathy. So thoracic aortic aneurysms are largely asymptomatic until a sudden and a catastrophic event occurs, like an aortic dissection or rupture. Advanced age, male sex, arterial hypertension, and aortic aneurysms confer the greatest population risk. But let's not forget the genetic connective tissue disorders such as Marfan syndrome, Loeys-Dietz, and Ehlers-Danios, plus patients with bicuspid aortic valves who are at a much higher risk at a younger age. So my take-home message here is that whatever exercise guidance you give your individual, it needs to be individualized. It isn't that one size fits all. Is aortic root enlargement a feature of intensive exercise? So there are lots of studies out there. I'm only going to present 2 main studies. This one by Beretta, who looked at 3,281 elite athletes with a mean age of 23 years. They were participating in 54 different sporting disciplines and exercise for around 19 hours per week. And this was an echo-based study. And so following their echoes, what they found was that the vast majority of their athletes, be it male or females, had an aorta within the normal range for the general population. Only 1.8% of men and 1.5% of women had an aortic value more than 40 millimeters and 34 millimeters respectively. And the greater size in athletes was associated with the high dynamic component, and body surface area also influences the size of their aorta. Now, this study by our group in a British UK, in a British population of athletes, where we looked at 3,781 athletes aged between 14 and 35 years old. These individuals were participating at a regional or a national level in 38 different sporting disciplines, engaging in around 16 hours of exercise per week. And they were compared with 806 sedentary controls from the CRY screening database who were age and sex matched. And again, this is an echo-based study. First point to note is that the 99th percentile value for the aortic root diameter in your control males and females was 38 millimeters and 36 millimeters respectively. Only 2.4% of male athletes, that is 58, and 2.3% of female athletes, that's 32 athletes, had an enlarged aortic diameter. The aortic root measured more than 40 millimeters in 5 male athletes and more than 38 millimeters in 6 female athletes compared to none of the respective controls. And over a mean follow-up of 5 years, none of the male or the female athletes with an enlarged aortic root showed a significant increase in their aortic diameter. And there were no aortic events reported amongst the entire athletic cohort, including those with an enlarged aortic diameter. So the take-home messages here from studies in athletes is that a dilated aortic root of more than 40 millimeters is not a feature of athlete's heart. Only a small minority of young athletes have an enlarged aortic diameter, and there was no progressive enlargement or aortic events observed in these athletes over a 5-year follow-up period. We can see that this is a short follow-up period, so we don't actually know what happens to these athletes with an aorta of more than 40 millimeters over a 10 to 15-year period. What about the risk of dissection with exercise? So there is a theoretical risk that with exercise, you increase your blood pressure, there is wall tension, and if your aorta is more than 40 millimeters, it will potentially result in a further expansion of the aorta, and you will be at risk of an aortic dissection. Having gone through the literature, currently there are no randomized control trials on competitive sports in those with thoracic aortic disease, which also includes patients with Marfan syndrome. And there is also no prospective data in terms of athletic activity in those who have had a thoracic corrective surgery. So as it stands, those who've undergone surgery, those with Marfan syndrome, those with Loeys-Dietz syndrome, or other hereditary thoracic aortic disorders, there still is a potential risk of dissection with intensive exercise. But I still want you to hold on to the fact that exercise does still bring you many benefits. It improves blood pressure. It's going to treat obesity and diabetes. It's good for your psyche. So the guidelines still recommend that physical activity is advised in all patients with an aortic pathology. The question we have to ask is, how much can I do with these conditions? Now, there is this small prospective study in Marfan patients. There were 19 Marfan patients in this particular study who underwent a 3-week rehab training program with a mean age of 47 years. And they were followed up for 12 months. And what they found was that no adverse events were reported during this period. There was an improvement in fitness. There's a reduction in psychological distress, but unfortunately, they did not provide any information on their aortic diameters. What about is exercise associated with the risk of aortic dissection? So again, there are 49 case reports of exercise-related acute thoracic aortic dissections, so the type A type of dissections, and these were predominantly in lifters. So 26 of the 49 were found in weightlifting, so power sport does put you at risk. There's also this other study on 615 patients with an acute type A dissection, of which 4.1% were related to sports. The type of sports that was most often reported was golf, but what they didn't provide is that the percentage of participants within the sport. And I guess one could consider that golfers were older and at increased risk of hypertension, potentially putting them at risk. What about the effects of exercise on the aortic diameter and wall stress? So there are mice studies out there based on the Marfan mouse model, where these mice were made to run on a treadmill at a multi-moderate dynamic exercise component. And what they found was that there was a reduction in the growth rate of the aortic diameter in mice with the Marfan syndrome compared to those mice who were sedentary with the Marfan syndrome. The aortic wall became stronger, and the optimum protective effects were at a training intensity of 55 to 65% of your peak VO2. And what that basically equates to is light to moderate intensity exercise, and I'll go through the parameters shortly with you. There's another study in individuals with bicuspid aortic valves. This study on bicuspid aortic valves in competitive athletes. So 58 athletes in this study. It's a cross-sectional study. The age range was 8 to 60 years. And these individuals were training regularly for an average of 14 years. The range was between 7 and 23 years. Again, they were evaluated with echocardiography, and what they found was that the aortic dimensions at all levels were significantly greater in athletes with a bicuspid valve compared to athletes with a normal tricuspid valve. We know that some of our bicuspid aortic valve patients have an enlarged aorta. But what was interesting from this study was that there was no correlation between the aortic dimensions and the duration of training. So based on these studies of a mild to moderate duration, there doesn't seem to be an impact of intensive exercise. But one clearly concedes that, patients with bicuspid aortic valves have a different pathological process compared to someone such as with Marfan syndrome. So this brings me on to the exercise recommendations. And I have to say that most individuals with an aortic pathology will benefit from a minimum exercise program and can participate in recreational sports. But I'd like to go through in more detail with you. So the first thing to note, it's really important that the management of a patient with a thoracic aortic problem has a detailed evaluation in terms of assessment of their symptomatic status. We do a physical examination, do an ECG looking for other patterns of pathology. They undergo imaging assessment with echocardiography and or a CT or a cardiac MRI, depending on what's available at your trust, to assess the aortic dimensions, check the mitral valve to see whether there is mitral valve prolapse, check their cardiac dimensions and function. And then I think it's also important to do an exercise stress test to check for any exercise-induced symptoms, check what their blood pressure is doing during exercise, and assess them to the level of exercise that they want to potentially do. Your step 4 should include make your recommendations in terms of type, intensity, and duration of exercise. And the final step should be that individuals with Marfan syndrome or any other hereditary thoracic aortic disorder should remain under surveillance and follow-up. So there is this very neat table for clinicians within this document where we have identified indices of exercise intensity according to the traffic light system, depending on what's available in terms of testing. If you have cardiopulmonary exercise testing available, you could use the parameters in your second column, but the vast majority will work according to your maximum heart rate for age. So light intensity equates to less than 55% of your maximum heart rate, moderate intensity up to 74%, high intensity up to 90% of your maximum heart rate. And so this is what you can reach out for when you're giving the guidance on exercise to your patients in clinic as to what level you want them to remain at, especially the vast majority of people out there now use Garmin watches or Whoop watches or Apple watches to track their heart rate. We've also provided this figure within the document, which identifies different sports according to the different intensities within your skill, power, mix, and endurance categories. So if you have someone come up to you saying, oh, I want to do fencing, and clearly that is a mixed stop-start type of sport, and it's regarded within a high intensity category. Which brings me on to the actual exercise recommendations. Again, it follows a traffic light system, and I'd like to go through these in more detail with you. So in your low risk category, so in your green box, are those individuals who have an aorta of less than 40 millimeters, in those with a bicuspid aortic valve or a tricuspid valve, or if you have Turner syndrome without aortic dilatation, then all sports are permitted, but preference needs to be given to endurance type of sports over power sports. And these individuals should be kept under follow-up every 2 to 3 years. So this is your low risk category. In your yellow category, so your low to intermediate risk group, are your Marfan syndrome patients and other hereditary thoracic aortic disorder type patients without aortic dilatation. And I do stress without aortic dilatation. Those who have an aorta between 40 and 45 millimeters in a bicuspid aortic valve or a tricuspid aortic valve, or if you've had successful thoracic surgery for a bicuspid valve or other low risk situations, then the advice is avoid high or very high intensity exercise, contact sports or power sports, and preference really should be given to endurance over power sports. And these individuals should be kept under follow-up every 1 to 2 years. Now, this is where most of your patients will fall into, which is the intermediate category or intermediate risk group, where you have moderate aortic dilatation, so an aorta between 40 and 45 millimeters in a Marfan patient or other hereditary thoracic aortic disorders, between 45 and 50 millimeters in a bicuspid aortic valve or a tricuspid valve. If you've got Turner syndrome with an aortic size index between 20 and 25 millimeters per meter squared, or if you have tetralogy of Fallot of less than 50. Or if you've had a successful thoracic surgery for Marfan syndrome or other hereditary thoracic disorders, you fall into this category. And here, we advise only skill sports or mixed sports, which is stop-start sports, or endurance sports at a low intensity. So this equates to less than 55% of your maximum heart rate for your age. And so the follow-up for these individuals should be every 6 months to a year. And if there is a change in symptomatic status, then you need to see them and reevaluate. In the red category is your high-risk group. So those with severe aortic dilatation. Someone's got their microphone on. Okay, so if you've got severe aortic dilatation with an aorta more than 45 millimeters in Marfan syndrome or other hereditary thoracic disorders, or more than 50 millimeters in a bicuspid valve or a tricuspid valve, if you've got Turner syndrome with an aortic size index of more than 25 or a tetralogy of Fallot of more than 50, or if you've had surgery and there are complications, then sports are temporarily contraindicated in this situation until you've had your aorta repaired. You would then reevaluate with clinical assessment and then give your individual the guidance that they require. So the key messages here are there is a lack of knowledge on the impact of sports on the progression of aortic disease and the risk of dissection or aortic rupture amongst individuals with an aortopathy. We simply do not have any randomized control trials, and the studies that are available are really based on small number of patients. And we've got a gold mine of patients out there who we could have a look at, give some exercise advice and reevaluate. These studies are waiting to be done. Prior to engaging in exercise, risk stratification with careful assessment with advanced imaging of the aorta and exercise testing with blood pressure assessment is recommended. You need to check whether they have an exaggerated blood pressure response to exercise, because that will impact their aorta. Regular follow-up, including an up-to-date risk assessment, is recommended. Dynamic exercise should be considered more suitable than static exercise. Participation in competitive and leisure time sports activities should be considered in low-risk individuals. Participation in individualized leisure exercise programs may be considered in high-risk individuals, but competitive sports is not recommended, and that's a level 3 recommendation. That's the end of my talk. I will take any questions. If you're interested in ESC preventive cardiology or learning more about sports cardiology, come and join us in Athens between 25th and 27th of April. Thank you very much.
Thank you so much, Dr. Gati. Our helpline is flooded with questions from youngsters. I aspire to or emulate. I think Isaiah Austin has Marfan syndrome and plays basketball competitively, which is really not to be recommended. But does anyone have a question for Dr. Gati? I'm sure you do.
It's all very clear.
I just have a quick comment, if I may. It's Anne Child here. When I've asked patients, is it any advantage having Marfan syndrome? I get some very interesting answers back. One chap won a school sailing competition several years in a row. And I said, how do you do that? And he said, when we go around the buoy, somebody has to lean out of the boat and stabilize it so that we can get round the buoy quickly. He said, I'm the tallest. I lean out the farthest and we get round the buoy really quickly and we win all the races. So there's a good success story for you. But you do have to watch the boom if you're tall. So sailing, archery, we have another archery chap who has lovely long arms and his eyesight is quite good. So he cleaned up school, county, national school. He won all the prizes. And table tennis, we have two twins who play on the same side of the table and nothing gets past them. So they win all the table tennis. So it isn't all gloom and doom. There are some advantages to having Marfan syndrome. Do you have any comment about other sports?
Dr. Child, you make a very important point. And I think, if you've got Marfan syndrome, you've got to think, how can I use my body shape and size to my advantage? Like, as you said, archery is actually really good for these individuals, actually, because it helps build an upper arm muscle strength. I've certainly tried out archery, and I can tell you really do need slightly stronger muscles, and it does help you build on that aspect. It also helps build on your stature and your physique, how you stand from that perspective, and you can use it to your advantage in terms of your arm length, for sure. I like to think swimming is good for patients with Marfan syndrome. It has less of an impact on their joints. They have a tall stature, they have long arms and long legs that they can potentially use to their advantage. In terms of building on some degree of muscle strength, it's not that we want you to become bulky, we actually want you to just be toned. And so to remain toned, I guess you can, although we say try and avoid power type of sports, but it's important to stay toned. So we say 20% of 20% for the upper body weight from your total body weight, and 50% of your total body weight for your lower legs in terms of toning. So you can pick up 2 to 4 kilogram dumbbells and work on those muscles, or work on those legs from that perspective to help you stay toned. But will you build on muscle bulk? It's a difficult one. I haven't really seen any of my Marfan patients become strong bodybuilders, but I really don't want you to become a strong bodybuilder from that perspective, given what the data suggests in terms of weightlifters.
I think Eleanor has a question. Eleanor Hyde.
Hi, Eleanor.
Hi, Dr. Gati, thank you very much. That's really interesting. And I had my hand up because I was going to ask, but you've kind of already answered my question. Perhaps I can just sketch the context. We women in our 40s I'm talking about me now, we get advised we have to do, with menopause coming up, we have to keep our exercise up, we have to do weight-bearing exercise to help prevent osteoporosis. So at the moment I have like 1 little kilo, 2 little 1 kilo weights, but I understand it's an individual case. You can never comment on an individual person. But generally, would I be able to have more than 1 kilo, do you think? If you're saying 20% of your upper body weight, if you see what I mean, that's quite a lot, actually.
Yeah. It does depend on the size of your aorta. That's what I am going to say. But you do need to obviously discuss that with your clinician. But you need to do the types of exercises which you are comfortable with and which doesn't cause an aftermath of pain. Because if it's causing you lots of pain, then that's the wrong exercise to do. What I like to suggest is using resistance bands. So you can get resistance bands and you can hook them up to a pillar or a pole of some sort, and you can do those. That really helps from that perspective. In terms of working on the legs, and Dr. Chand and I were talking about this earlier on, treading in water, so against the resistance, that's a form of resistance workout. Again, it has less of an impact on the joints, and it's going to help you build or strengthen those muscles as well from that perspective. If you're going to go to the gym and work out at the gym, I suggest you use the controlled machines where you know exactly what weight that you're working with in terms of working on the legs and the upper arms. And if in doubt, you can ask the physios. They're well equipped with giving advice to Marfan patients from that perspective.
Great, thank you very much.
One of our supporters asked persistently about rowing. He's an avid rower, and his long levers confer a kind of natural advantage. Is this to be advised in Marfan syndrome?
I've only tried the rowing. I have to be honest, I've only tried the rowing machines at the gym, which are one of those rather than the ones in the actual water. I presume it's okay, but I would say if it's causing an aftermath of joint ache within the elbows, because obviously with Marfan patients, you can be double jointed from that aspect, and if it's causing an impact and it's causing damage, then it wouldn't be recommended. But again, it needs to be individualized. So if it's not causing a problem for this individual, then I don't see why it's not a problem. Why they can do it, as far as I'm concerned.
Yeah, he's quite evangelical about it because he said his bill's just so conducive to it. And
every patient will vary, because every Marfan patient is not the same as every other Marfan patient. You know, you might have slightly more or more of a pectus than someone else, or your joints at the elbows may be slightly more or angulated than someone else's. It, you know, for example, within archery as well, you know, the way they teach you the technique is different for someone who's, you know, hyper flexible compared to someone who's not. So it varies. You need to be given the right advice by the right person who's training you within that sport. But if it's for fun, it's okay, because it's of a light intensity anyway.
Thank you. Amanda said that her 39-year-old son has had aortic root and valve replacement, has also had a repair of a type B dissection. He continues to play tennis competitively and also pushes himself to maximize his performance in swimming and on his exercise bike. I keep telling him this is unwise, but he tells me that fitness is important.
He's right in a sense that fitness is important, because as you've heard, it helps with your blood pressure, it helps, you know, reduce obesity, diabetes, it's good for men in terms of prostate cancer and dementia, but it's how much you can do. So as it stands, we don't have the data. Basically, we don't have any data in the literature as to whether it's going to have a long-term impact. You know, I never like to say to my patients, don't exercise unless they were, you know, at some significant risk. So all individuals need to take on board some level of risk. It's some of it is your responsibility, some of it is the clinician's responsibility. And as a clinician who gives lots of guidance in her sports cardiology clinic, you know, having done the assessment, I think it's really important that you discuss the risks, and it's a shared decision making process. As long as, you know, your son understands that he is potentially carrying a risk, that he may potentially re-dissect again, you know, and it could be at risk of, you know, a sudden cardiac death, and he's willing to take that risk, I don't think we should be the ones to stop anyone from doing what makes them happy. I think we've got to give the explanation. You've done your bit. Obviously, you know, it's different when it's your own child, you worry about them. I appreciate that, but equally, you know, I don't think we should be the ones saying that don't exercise. But that's my take. That's my take.
Thank you very much.
Thank you. Very practical lecture.